Thank you, Chairman. And I would like to appreciate the organizer of COE International Symposium because of providing me the opportunity to present our performance and achievement in the field of islet transplantation at Kyoto University. I'll start my presentation. This is the overview of islet isolation and transplantation. We first make pancreas into the small pieces of tissue using a collagenase. Collagenase can break down the connection of the tissues. And we can see, I have no pointer, but I will show you. We can see the small islets stained red with an decision staining. It's a special staining. And this process for making the small pieces of tissue, we call this dissociation of pancreas. And after the dissociation of pancreas, thanks so much. After the dissociation, we collect the islets only from the dissociated tissue. And this process, we call it purification. And after the purification, we suspend the islets into the solution and inject into the portal vein to the catheter inserted through the skin and the parenchyma of liver. And after the injection of the into the portal vein, islets go into the sinusoid around there and are located there and start again to function just like as in the pancreas. We call it engraftment. It's a whole procedure of islet isolation and transplantation. The clinical islet transplantation in a worldwide scale in 2000, since the report made from the University of Alberta. The report was they got an insulin independence and 7 type 1 diabetic patients after the islet transplantation. The procedure, what they did, we call it the Edmonton protocol. Edmonton protocol has at least 3 characters. The first is an islet transplantation alone with optimized immunosuppression, meaning without any steroids. And the second one is they used flesh islets to transplant without any culture, neither or the cryopreserved. And they did multiple transplantation from 2 to 3 donors to the single recipient within a relatively small period. And our 3 institutions in the Northwest, North American, meaning the University of Alberta, University of Minnesota, and also University of Miami, did the same protocol using an Edmonton protocol and getting the same results, meaning the 80% of the patients receiving the islet transplantation got their insulin independent at least 1 year after the islet transplantation. But Lyon at University of Alberta reported in 2005 the long-term outcome of the Edmonton protocol. He showed the loss of her rate of insulin independence as the time passed. At the point of the 3 year, it shows 20% insulin independence, and at the 5 years after transplantation, the insulin independence rate are lower than the 10%. But for the same patients, they show their C-peptide positive, meaning the partial graft functioning. And Lion also shows even they start the insulin again, as long as they got insulin and endogenous secretion, the glycemic stability can be gotten by the patients. And they are planning to other March Center of Edmonton protocol, trial of Edmonton protocol, and they are reported the results of that in 2006. And this report shows the similar, quite similar outcome to the outcome obtained at the single center at University of Alberta. And the conclusion said, islet transplantation with the use of the Edmonton protocol can successfully restore long-term endogenous insulin production and glycemic stability in subjects with type 1 diabetes mellitus and unstable control. But insulin independence is usually not sustainable. Persistent islet function, even without insulin independence, provides both protection from severe hypoglycemia and improved level of glycated hemoglobin. This is the consensus of the status of islet transplantation currently. And based upon this achievement, they are in the United States and also in European planning to do a phase 3 clinical trial of islet transplantation, meaning it's the final step to establish the islet transplantation as our standardized option to treat type 1 diabetes. And in Japan, we would like to start islet transplantation as well. And fortunately, at Kyoto University, they have been already the cell processing center. And this was planned to build by Dr. Uchiyama and is run by Dr. Maekawa currently. And using part of this, we can make an islet isolated within the current GMP level. It was very good. But for another issue, to start an islet transplantation in Japan, it was quite challenging. For example, the issue of donor. The available donor for islet transplantation is restricted to non-heart beating donor, also to living donor. Because the pancreas from brain dead donor are used for only pancreas transplantation in Japan. To start islet transplantation using non-heart beating donors based on the Edmonton protocol, we had to modify the isolation method, because the current standard isolation method used in European country are made for brain dead donor. It's a good condition. It's better condition than the non-heart beating donors. So we modified some steps during the isolation. We added a modification for 2 steps. One, we use an Kyoto solution instead of UW solution in the storage process. And also we use an Kyoto solution and iodexanol instead of FICO and purification process. And this is key. Our Kyoto solution is key in our modification. And I will explain some of it. And Kyoto solution is the combined of Kyoto solution with urinestatine. And Kyoto solution is initially developed at Kyoto University by Dr. Wada for the storage of lung transplant. And it contains extracellular composition, meaning high sodium and low potassium. And it contains trehalose as a sugar for energy storage. And it can be stored at room temperature for a long period, meaning it's very stable. And urinostachin is a trypsin inhibitor and also has an anti-inflammatory effect. And it has already clinically used for the treatment of pancreatitis only in Japan. And this is a table to showing the beneficial aspect of the ET code solution comparing to the UW solution. And ET code solution has a lower potassium than the UW solution, meaning that ET code M code solution is less stimulating beta cells. And UW solution has a lactobionate and raffinose. They have an inhibitory effect for the collagenase activity. But M code solution does not have these of them. And instead of that, M code solution has a trehalose. Trehalose have an effect to protect the cells. And also M code solution has an urinostachin. Urinostachin has an effect to protect their islets from other attack of the trypsin. Okay, it's great. And also there is another big character in the M code solution. M code solution has low viscosity, means very thin. Using the porcine islet, we are evaluated our modification is really useful or not. And using an M code solution instead of UW solution, after that dissociation, before the purification, we was able to got more islets, almost 2 times. And using an M code solution and iodexanol instead of FICO solution, we get more islet and combine with them, meaning M code solution for the storage and M code solution and iodexanol for purification, can get almost 3 times better yield than the standard one. This is the standard one. And we will call this method a cured islet isolation method. And I will show you some mechanical issue why we can get the better islet yield using an M code solution instead of FICO solution and the purification process. Okay, and you know the FICO solution is very thick. Otherwise, on the other hand, the ET code solution, M code solution is very thin. And we measure the viscosity for the every density for the FICO and also the M code solution and iodexanol. And iodexanol and M code solution shows constantly the lower viscosity for every density. And we measure the size of the islets before the purification and after the purification. And this is the histogram of the islets before the purification. The vertical axis shows the islet diameter, and the longitudinal axis shows a number, so it's a histogram. The distribution of the islet size before purification is like this. But after the purification using the FICO, islets has a very small size. And in other hands, M code iodexanol purification process, they shows very similar with that before purification. And that means that the islets are destroyed during the purification more in FICO solution. We thought the mechanical forces like shear can work like this. And we plan to measure or calculate the shear during the purification process with an FICO and also with an M-iodexanol. For that, we are molded several points of the cold bags during the purification and measured size and put all the data into the computer and using a supercomputer for at least 2 days and gotten a results. And the results said the total shear during the purification process with the FICO solution has more than 10 times than the shear during the purification process using an M-Kyoto and iodexanol. We think this is some part of some mechanism why we can get the better islets using the M-Kyoto and iodexanol and the purification process. And using an Kyoto islet isolation method for the clinical islet transplantation, we have another big factor to perform the islet clinical islet transplant isolation and transplantation. This is that. This is an in situ regional cooling system for pancreas, meaning before the cessation of heart beating, we are gotten informed consent from the family of the patients, and we insert two double balloon catheter through the femoral artery. And just immediately after the cessation of the heart beating, we inflate other balloons of the catheter and flush it with a very cold solution. So we can minimize the worm escape time, and we are able to get quite good pancreas in quite good condition. Using this system and also using an islet isolation, Kyoto islet isolation method, we performed 25 islet isolation, and 20 out of them we were able to transplant to our 9 type 1 diabetic patients. The success rate was 80%. It's quite high, I believe. And this is, I will show the first case. It was, the subject was a 36-year-old female, and she suffered from type 1 diabetes, and the onset was 40 years old. And since then, she shows frequent hypoglycemia. And complication was retinopathy was treated, and a little bit albuminuria. And she got 2 injections of islets isolated. And after the first eye transplantation, her blood glucose shows a very narrow range between 50 to 150. And after secondary transplantation, the range gets narrower. And she got an insulin independent after the 17 days after second eye transplantation. And we also have an islet after kidney transplantation program. It started September in 2006, last year. And the inclusion criteria for that the subjects should bear the kidney allograft more than 6 months, and with a serum creatinine level less than 1.8 milligram with a stable renal function, and subjects should have less than 10 milligram per day a dose of steroid. This islet and kidney, or this islet after kidney transplantation studied based on some evidence like this. This results reported by Dr. Cecchi, who were working at University of Milan, Italy, and he compared the patients bearing their islet and kidney allograft. And between the patients with an islet function and without islet function. And he got results of a higher survival rate of renal allograft with an islet in patients with an islet function than the patients without islet function. That means a functioning islet can protect the kidney allograft. It was good for, to facilitate islet after kidney in Japan. We got a first case also, and I'll show it. It was a 38-year-old female, and type 1 diabetes onset was 70 years old. And actually, this patient got already the first islet transplantation. It's an islet transplantation alone when she was 36-year-old. And at that time, she showed a little bit renal dysfunction. But after the islet transplantation, she got a renal failure and got an induction of hemodialysis almost for 1 year. And after that, she got a living donor renal transplantation, actually from her mother, when she was 37-year-old. And we did the 2 additional islet transplantations for her. This is the first one as an islet after kidney transplantation. And 45 days since this, we got another pancreas and make an islet and transplant it to her. She got the steroid and tacrolimus and mycophenolate as a maintenance therapy of immunosuppressants. It means completely different from the Edmonton protocol, but it works very much. Now I'll show you. And, I'll show you first the renal function. The renal function did not change anything, even after the final islet transplantation. And blood glucose is very good. And also the insulin dose is decreasing, and shows a very good C-peptide and endogenous secretion. Now I'll show you finally other case we did at Kyoto University of an islet transplantation from living donor. For the living donor program, ethical committee of Kyoto University Graduate School and Faculty of Medicine did a very in-detail discussion and gave us a basic application after that. It's not the full application. And we have to ask the ethical committee for each cases. I'll show you the living-related transplantation, islet transplantation. We got the half part of the pancreas and make an islets and infused islet into the portal vein of the patients. And this is a recipient data, a 20-year-old female, and she is not the type 1. She is in pancreatic diabetic mellitus due to the pancreatectomy. And got an IDDM onset when she was a 15-year-old. And her donor was her mother, and the mother was a 57-year-old female, and she shows a very good metabolic assessment results. And also she meets all criteria to islet from the living donor islet transplantation. And we are measured the volume using a volumetry, and we found that if we put a cutting line at the left edge of the portal vein, we can get almost half, and the remnant will be half. And the pancreas was procured and make islet isolated. And notably, the data of the pancreas from the living donor shows a very interesting data comparing the non-whole beating donors we got at that time. The total yield was quite similar. This pancreas is almost half volume than this, and like this, and the rate is almost double. And some function test, meaning a stimulation index, shows a very high level, and living donor islets. And transplant them within the usual way. And after the transplantation, the recipient shows a very good glycemic control. And for the living donor islet transplantation, the purpose is not insulin independent. It's getting the glycemic stability. And fortunately, this patient got an insulin off 22 days after islet transplantation. And it's for donor. A donor was got an oral glucose tolerance test on 70 days after the pancreatectomy, and shows a normal pattern of blood glucose, and also the insulinogenic index normal level. And this is the endogenous insulin secretion. The recipient and also the donor shows a good secretion. And our donor has no change in hemoglobin A1C, and for the recipient, the hemoglobin A1C is getting close to our normal range. So here is a summary of this presentation. Under the necessity of using pancreas from non-heart beating donors for islet transplantation in Japan, we established the new islet isolation method by modifying the current standard one. We call this new method Kyoto islet isolation method. Using Kyoto islet isolation method, we were able to start and are able to continue both of islet transplantation alone and islet after kidney transplantation program using non-heart beating donors at Kyoto University. And Kyoto islet isolation method also contributed to perform islet transplantation from living donor because of its sufficient accuracy to isolate islets. Now we are making an effort to establish islet transplantation as a standardized option to treat insulin-independent diabetes mellitus with glycemic instability in Japan. Thank you. Oh, and finally, I would like to thank all of them and this slide. Without their contribution, we cannot do this performance. Thank you for your attention.